Okay, so glad you guys can join us. Today we are speaking with Dr. Otis Kirksey, the distinguished Dr. Otis Kirksey from Florida A&M University. And I just want to tell you all about the wonderful things he's done throughout his career. Today we are talking about Black men and diabetes, and we have one of the foremost experts in the country speaking about that. In addition to 30 plus years of academic leadership and nonprofit leadership, Mr. Kirksey has leveraged his clinical skills in program administration, public speaking, teaching, research, publication, and clinical practice. His specific interest has to do with the issue of diabetes in our community. Among his certifications, he's a board certified advanced diabetes management certification person with the American Association of Diabetes Educators. He's a certified diabetes care and education specialist as well. He's had faculty appointments with the College of Pharmacy and Pharmaceutical Sciences at Florida A&M University. He was also named an eminent scholar chair in pharmacy practice at Florida A&M University. And currently, he serves as the director of pharmacy services with the Neighborhood Medical Center in Tallahassee, Florida, where he's been serving since 2018. Without further ado, I'd like to welcome you all to Mr. Dr. Otis Kirksey as we talk about the issue of Black men, Black people, and diabetes. Welcome, Dr. Kirksey.
Good evening, good afternoon. Thank you for inviting me.
Right now, I know you're a distinguished alum with Florida A&M University, and from what I understand, the homecoming, the post-pandemic year homecoming was extraordinary. And so I want to ask you, as someone who wasn't able to go this year, on a scale of 1 to 10, what would you rate the homecoming at this year's Florida A&M University this year?
12.
Wow, okay. And why?
Yeah, well, I am, in addition to being committed to diabetes and so forth, I tailgate every game. And when I say tailgate, we tailgate. And so it was so nice after 2 years of being down to come back and have so many people there. It was truly a family reunion. We not only had the game going on, but we had a lot going on outside off the football field as well. With Will Packer, dedicating the amphitheater and other, great things going on. We had several celebrities there, and the atmosphere was just beautiful. And on top of that, the Rattlers were kicking butt, so that's always good, man. When we're winning. So I'm old school Rattler. When we went to football games, it wasn't about whether or not we were going to win. It was going to be about where the party's going to be after the game. So, we really enjoyed having a team that was extremely competitive this year in the face of, what we were dealing with. Another thing is that, this pandemic, man, people, it has been associated with development, depression, anxiety, a lot of other mental disorders and stress. And so we really needed it. So it came at a very good time. And I think that's why it was extraordinary, because people were just so excited to be able to get out, hug, touch, within reason, and just be close to folks.
Absolutely. That's awesome. Well, I also want to ask you, there's something else that I noticed when I was doing research on you. You are an avid golfer. Someone asked you this question. On a scale of 1 to 10, how would you rate your golf game?
Oh man, depends on who's rating it. Okay, if I'm rating it, look, I in terms of enjoyment, I give myself a 10.
Yeah.
Okay, I've been playing the game for a while. I will never make money playing the game, but every day is a challenge, and that's what you go out there and look for, So I would give myself a good 5 in terms of,
Okay.
How well I can hang with the guys I play with. I'm about 5, 10 years older than them, So they all hit the ball long, but I tell them they hit the ball long and wrong. I'm short and straight up the middle. Okay,
That's
so
right.
right. So, but in terms of enjoyment, I give myself a 10. That's what the game is all about.
Mm. What is the like most beautiful course you've ever played on?
Oh man, well, I was just in Hilton Head for Thanksgiving, so that was a real nice course. And
Wow.
yeah, and I played in I can't remember the name of this course, but it was in California, right outside of LA, and it was in the side of a mountain. And I mean, it was just simply gorgeous, to play that and have the mountains in the background and so forth. So yeah.
Wow. 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 Okay, that sounds awesome. Hilton Head too. Wow, that's it's beautiful out there.
Yes, it is.
Hmm. So when we start these, we like to talk about like your background, like
Okay.
where you came from. And if I'm not mistaken, you're from originally Daytona Beach, Florida. Is
Daytona
that
Beach,
right?
Florida. That's right around the corner from Bethune-Cookman College.
Oh wow. Oh wow.
Yeah,
And you went to FAMU. Okay.
yeah. My mother played basketball for Bethune, and actually she played against our Bill Gibson.
Oh wow.
Right. And my father was best friends with Miss Bethune's grandson, Albert. So
Wow.
yeah, we were very closely tied to Bethune-Cookman, and both my brothers played football for Cookman. I'm the only one that went to Florida A&M.
Wow. So how was that? Especially after the classic,
I
that's
just,
gotta
well,
be
my dad, my mother and brothers are no longer with us, but my
God
dad
rest
is
his soul.
91, and he's here. He lives at one of the local extended care, long-term care facilities. But I mean, it's nothing wrong with him but his knees, and he wear a Cookman gear every day. So I've been listening for the last 10 years, listening to him run his mouth. And well, after what was that game, man, he's been real quiet. So,
Right. Oh, that's awesome. Um, so when you were coming up, like who were your influences? Who helped shape you?
well, a couple of things, I always, first of all, I had a very strong mother who really was in active education. She was a teacher for many years before her death. But she had two brothers who were very supportive. Matter of fact, they helped pay for her education. They were pillars in my, found anchors in my development as a black male. And then my father there, while he wasn't in the house, he was also there. And so, I give the initial foundation to them, but also the community. One of my mentors was Dr. Richard B. Moore, who was the president of Bethune-Cookman at the time. And after I finished pharmacy school, looking for an internship, Mr. Moore was one of our trustees at our church, and he made sure that I did my internship at the local hospital. I was the first black intern or intern from Florida A&M to intern at Halifax Hospital, which was tremendous. But even before then, my interest in pharmacy, I had there was a black-owned drugstore. In fact, these brothers had two stores, one on each side of town, and Biggins and Meats. And the way it was supposed to go, I was supposed to go home and work in that store, eventually take over. But one died while I was in school, and another one, for medical reasons, they had to shut the store down. So the community influenced me, in terms of having those kind of people there, and friends of the family like Edward Creamy Hayes, who is my fraternity brother and mentor for a lifetime, who's no longer here. Those kind of people helped shape the person who I am today.
Hmm, hmm. Um, when it comes to like going to school and discovering what your academic interests are, what were they for you? And I mean, it led you to pharmacy naturally, I would imagine, but how did those interests come about for you?
Well, it's kind of interesting. My interest was either law or pharmacy. Pharmacy because of the relationship I had with Dr. Meeks and Dr. Biggins. Law, because I always was attracted to the profession. I was a talker and debater. I enjoyed doing those kind of things, and so I applied to Morehouse and got accepted. And I didn't apply to Florida A&M. I ended up at Florida A&M because there was a program that the College of Pharmacy sponsored, programs in health sciences for graduating seniors. And I did a 6-week residential experience right after high school at Famu. And that's where the pharmacy piece really took priority, because I didn't apply to FAMU until maybe August of before my freshman year started. And but it was because of the faculty and the whole atmosphere there of nurturing, mentoring, high expectations that attracted me, to FAMU, to the College of Pharmacy. So that has been, the rest is history now. But I always, wondered, what if I had mixed those two together, law and pharmacy, and some people are doing that. But yeah, that's how, I got to where I'm at now.
Mm. And when you got to Florida A&M, and when you think about that time, what was it about pharmacy that grabbed you, that made you want to pursue it further and even go to graduate school?
Well, one of the things, when I started pharmacy school, we were in the transition into clinical pharmacy. And so for a long time, pharmacists were really limited in terms of what they legally could do. Okay. And so when I was in school, the PharmD, that's a doctor of pharmacy, is a practitioner's degree, like the MD in medicine. The PharmD is a practitioner's degree, practice degree that was actually in its infancy, getting in the midst of being developed. And so along with that came, the interest in terms of doing disease state management, pharmacokinetics, and things like that. That really, just drew me in. The idea of providing. I mean, we've come a long ways now. Now we provide direct patient care, like I do every day at Neighborhood Medical Center. I do direct diabetes disease management one-on-one with patients. And so it was the evolution of the profession, along with, role models at the university that kind of, made me gravitate to this whole thing about pursuing a graduate degree, because a lot of my friends, when they graduated, they got their BS degree and they went to make money, and they were making money. Okay. They was offering $10,000 signing bonuses. I mean, you had about 10 or 12 offers and they were making money. And, I decided to stay and do additional 2 more years. I said, after 5 years for the BS, do additional 2 more years for the PharmD, which was then, it was treated like a graduate level degree, like getting a PhD with thesis, presentation, research, and all of that. And so, it was an investment up front, but the dividends are now being paid now, because, a lot of, I'm 61 now, and a lot of my classmates, they're burnt out. They've been standing behind the counter. Not that that's not a great job, but it's taxing. It takes physical stamina, and you can only do that for so long, and so now they're trying to maybe look at, moving into another direction. And so, I am in a position in terms of practicing where I can ride this wave for a long time, because it's not labor intensive, but it is intellectually challenging and also, I would say, satisfying.
Mm. Wow. And that PharmD degree, that allowed you to go into the classroom at a university level as well. Is that right?
For sure. That was the I came to family to teach after working several years. So I had, about 7 years of actual practice in Miami. I was actually over the investigational drug program at Jackson Memorial Medical Center, where I
Mm,
coordinated the drug research for a lot of new age drugs back then, and some of them actually proved to be life-saving, research that we were involved in. But to come here after bringing that experience here into the classroom, having that PharmD was needed, and you couldn't do it without it. Even though we had folks in there like Mr. Bob Scarborough, who from Michigan State, MS, who was the pharmacist. So, not saying they having a BS, a master's back then wasn't, qualifying, but the PharmD was the new trend, and so it opened the
mm.
door for me to get into academia.
Oh, wow. Wow. Now, when you talk about your experience at Jackson Memorial, are there any of the drugs that you care to mention that you were a part of seeing researched and released into the world that
Oh,
were
certainly.
life-saving?
Pentamidine, which is used for pneumocystis carinii pneumonia patients with HIV. Fluconazole. We One of the studies we did, they actually used one of the methodologies that we used back then. Patients were dying so fast from pneumonia. There was a study that was led by Margaret Fisher team, who we looked at the use of corticosteroids, right, in patients who developed pneumocystis chronic pneumonia, to see if it actually saved lives. And I was in charge of the blinding of that study. So the only person that knew who was getting the real drug was me. And
Mm,
we found we had to stop it after enrolling 30 people, because it was overwhelmingly effective in saving lives. And so now, with COVID, patients were dying from pneumonia. Okay, a lot of respiratory disorders, and they brought in corticosteroids. They use a lot of corticosteroids, on these patients. But that was we found that out and published in New England Journal of Medicine back
wow.
in the 80s.
Mm, wow. Wow. That's major.
Oh yeah, it saved lives. It
Mm,
was the drugs were people were dying so fast. The FDA created a new track, a fast track, and that's what concerned me about this whole thing about people concerned about how fast they put the vaccine together for COVID. Well, back in the 80s, people were dying so fast of HIV. The normal time that it takes a drug to go through the FDA process was, I forget now, 12, 15 years, whatever. They created a fast track to get these drugs through, get them on the market so that it could save lives. And now you look at HIV is a chronic condition. It's like having diabetes now.
mm.
It was a death sentence,
Yeah.
when back in the day. And so they were
Hmm.
able to come up with this fast track, to create these drugs so that patients would be able to benefit from them.
Mm, absolutely. Absolutely. Um, when I go back to those Florida A&M days, I mean, it's such a rich experience, and I can imagine it's was definitely the same for you. And so I wanted to ask you this question. Um, what's the most memorable lesson you received from your experience at FAMU? Um, and it could be a lesson that you still apply today, but if there's one that emerges or a couple, what lessons have stayed with you the longest from that experience?
Two of them. First is it relates to professional responsibility, and I was the president of the Student American Pharmaceutical Association, like the SGA of the College of Pharmacy, and that means I got to attend some of the state meetings. And back then, it was a real different world, man, in terms of I mean, it's still different now, but it was even worse. And so, I remember going to one of the meetings of the Florida Pharmacy Association, and I mentioned Mr. Scarborough, who was assistant dean, and And we were sitting there at dinner, and we were the only blacks out of about 300 or 400 people there. It was, our group, our dean, his wife, Mr. Scarborough, and myself, maybe a couple of students. And I said, man, I said, Mr. Scarborough, why do you come to this? He said, Otis, if I don't come, who will be here? What will the conversation be if I'm not here? I say I have a responsibility to be here to make sure that our perspective is shared and is and known. Okay, so that taught me the importance of being active in my professional organizations, and not only that, but going to meetings and participating. The other thing is that I learned to meet people where they are. And so and that I learned that regardless of what path a person is taking, man, is that you have to meet them where they are. And people, I always tell my students that patients don't care about how much you know until they know how much you care. And that whole thing about empathy, about compassion, I learned those lessons, from the faculty there at Florida A&M and how they manage their patients, approach their patients.
Yeah, it's powerful, very powerful. Being at the table and being able to share your experience in a room that's not overly representative, right?
Yes.
That's
Yes.
super powerful.
Yes.
Wow. So I wanted to ask you here about diabetes.
Okay.
When on your journey, academically, professionally, when did that become an area of interest for you? How did that occur?
Oh, it's a funny story, really. After joining faculty at the university, I was the junior faculty member there, in pharmacy practice. And I have now become colleagues of the people who taught me, and so when you're a junior faculty, man, you teach what they tell you to teach, right? So everybody had their own specialty. Prior to coming to Florida A&M, I had some interest in special immunology, like HIV and investigational drugs, but that immunology was already taken by Dr. Acelia Johnson Fannin. And so they gave me endocrine disorders. I mean, it was assigned to me. I didn't have the specialty. I didn't want specializing in it. But, once I began to prepare, to teach this, and I began to do research and learn a lot about the disease. My granddad was blind from diabetes. I had two uncles that suffered from diabetes. I have relatives who had amputations from diabetes. So it became personal also. And so the more I taught it, the more I developed this passion for it, and once you start looking at the health disparities, it really becomes personal, because, you look at the amputations and you look at hospitalizations and things like that, and you wonder, why is it so flipped? Why is it that, people that look like me are experiencing a greater percentage of the morbidity and mortality associated with the disease? So that the seed was planted, and the more I taught, the better I got at it, and then I create my clinical practice, because I was teaching diabetes. Then I began to focus on diabetes in my clinical practice, and so early on I was at the Tallahassee Memorial Residency Center, where I was a clinical pharmacist. On faculty with the faculty of the residency program, and while I did disease management in general, but diabetes was my focus. And you mentioned Neighborhood Medical Center. Well, I eventually gravitated to Bond Community Health Center, which is a very qualified community health center here in town that provides care to primarily African Americans. Is full primary care. I started there, and really I began to see the challenges that people of color have in dealing with this disease. I know we're going to talk about it in more greater detail in terms of what the challenges are, But it was that is how it came about, and I eventually gravitated to neighborhood medical center where I stayed there, faculty at university, but practicing at neighborhood, and I did it for about 15 years. And so, yeah, that's how I got into that diabetes space, and it's like a magnet, really, man. Once I, I guess bit the cheese, man, I was in.
Yeah, and that's a perfect segue, because there's a question that I wanted to ask you. There's a statistic that says that the average African American adult has a 50% chance of developing diabetes in his or her lifetime. That seems really high. What factors, in your opinion, what factors have influenced or contributed to that trend?
Well, it's complicated. Well, I'll tell you this: the most profound predictor of developing or risk factor for the developing type 2 diabetes. And let me just say that type 2 diabetes is the type of diabetes that typically occurs in the third or fourth decade of life. It typically affects people of color, communities of color, even though a lot of white people have type 2 diabetes. And these patients typically not necessarily have to live with insulin. A lot of them do use insulin, as opposed to type 1, which represents only about 5 to 10% of the diabetic population, which typically occurs early in life and typically affects white kids. So when we look at risk factors for type 2 diabetes, the most profound risk factor is obesity. And if you look at the obesity rates and the diabetes rates, you could graph them there. You can almost superimpose the two. So now the question is, why is the obesity rate, in the African American community, higher than that in the white, like other communities? And there's a lot of factors that contribute to that. Cultural factors, okay, in terms of what we eat, the type of foods we eat, and we know, where that culture comes from. Back in the day, we had to eat the leftovers, what was left, what the slave master didn't want. Okay, those are things. So we had the fatty cuts of the meat, and we eating a lot of rice, and high density carbohydrates and things like that. And so you got cultural issues, but you also have social issues that contribute to the intensification of the rates of diabetes, and ultimately the rates. The rates of obesity, and ultimately the rate of diabetes. And so you have like these social determinants of health that come in, like living in Tallahassee. If you get to college here. Well, on the south side, when you were in school, you had Winn-Dixie. That was a throne. You could walk right out, the complex, and go right to Winn-Dixie, right? So the people that lived on that south side in the area, they could walk from Southside Project, through the parking lot of the other shopping center to Winn-Dixie. Well, Winn-Dixie moved out of that space and went almost a mile and a half down the road. Okay? So, and then they blocked any grocery store from, they own the property, would not lease to any other grocery store for that space. So those people now, if you don't have a car, right, and you got to go to the grocery store, so what, that's why you find so many shopping carts, in the projects, because it's unrealistic for them to carry those groceries that far. And so that we call it a food desert. There's no access to, it created a void, no access to healthy foods, okay, fresh vegetables, nice cuts of meat at reasonable cost, okay. And so we were fortunately, through our city government and other community leaders are able to bring in Piggly Wiggly, who fill that void now. Because when Dixie, the spot where they moved to, they've gone. You follow me? Okay, so that's a food desert. All right. So what's the opposite of food desert? The opposite of food desert is a junk food junkyard, right? Okay, so you got corner stores and fast food restaurants. It's called junk food swamp. That's what it is, swamps. Because they can go to the corner store and you can buy all of the high carbohydrate, the chips and the cookies and the malt liquor and all of that. Those on every corner. Okay, so when you look at what the options that are readily available, in addition to behavioral and cultural issues, the intersection of that, man, is a high rates of obesity, diabetes, and ultimately, amputations, complications associated with disease and so forth. Now, the other piece is social determinants in terms of income. People, even though now there are a lot of jobs available, and I don't understand why not, but you have to work 2 part-time jobs to get a full-time job, right? So you come home, you got time to cook. You're looking at things easy, hamburger helper, it's cheap, things like that. Okay, not having access to health care, or not being able to afford the medications they need, all those social determinants of health. But in summary, the rates of diabetes associated that are influenced by the social determinants of health, all of that is connected. You cannot separate the two.
I would imagine there's a mental health component as well in there, right?
For sure. What some people often ask, does depression precedes diabetes, or does diabetes bring on depression? We did a small study of our patients. Neighborhood Medical Center is also a community health center that you can get primary care, mental health, so forth, for uninsured patients. Okay, we did a survey of about 120 patients, and we asked them we use this Zung scale. It's a scale that people can actually self-report symptoms of depression. We found that over 30% of our patients had symptoms of mild to moderate depression. Okay, they reported them themselves. Okay, so when you look at in terms of the stress of paying bills, the stress of living in this country as a Black person, okay, all of that's a burden. Diabetes in itself is a burden. I had a patient recently who I've been managing for several years, and we have a very good relationship. And she came in one day. Normally she's very cheerful. This time she was burdened, and she's and I was saying why you not just said that the Kirksey said sometimes I just don't care. And I said, well, you got grandkids? She said, yeah, I got grandkids. I said, well, don't you want Big Mom to be around that? She said, oh, Dr. Kirksey, sometimes I just don't care. It's so overwhelming. And so, yeah, depression is a big mental health, anxiety, all of that, is adds to it. And another thing is that, very few people have just diabetes. Diabetes is like, the buddy you invite to the party and they bring a whole other, 5 or 6 other people. So you don't only got diabetes, but you got high blood pressure, you got high cholesterol, and if you're older, you may have arthritis, right? Or you may have asthma, which is big in the African American community. Okay? And so all of that, can be a tremendous burden. Taking injections, sticking your finger to get your blood sugar. Just think if you had to stick your finger 4 times a day in type 1, or you had to stick your finger every morning. I don't care what anybody say, it hurts. And so now we're looking at disparities in access to continuous glucose monitoring devices, where you can put the patch on and put your phone here and check your blood sugar without even sticking yourself. All right. So now we have disparities in terms of access to technology that can revolutionize in terms of how we manage the disease. So it's all connected.
Wow. Yeah, it's really sobering. And would it be safe to assume that this is a public health crisis, especially in the African American community?
It is a public health crisis. It's not safe to say it is. The truth is the truth. And one of the things that I'm president-elect of the American Diabetes Association, and will be taking over as president in January. And one of the things we found, initially 40% of the people that died from COVID had diabetes. Okay, so what COVID did was COVID pulled back the skin on the onion and showed the ugly truth in terms of the health disparities that exist. In terms of all those things we talked about earlier, social determinants of health, they were all contributing to the deaths that we saw in patients, with COVID and so forth. So yeah, it is a crisis because when you're taking, some of it can be fixed. You got to have access to care. You got to have affordable medications. You got to provide access to transportation so people can get to the doctor. When you're an hourly wage worker and you got to go to 3 appointments in 1 week, you taking an hour, your check gonna be 3 hours short, and you counting every penny on that check. Okay, so yeah, it is a crisis. I am so excited that now the health equity issue has now taken front and center stage. And I think it was a combination of COVID and George Floyd that we're now looking at health equity as opposed to health equality. And people get the two mixed up, And so, you give health, equality. Everybody get a ticket to go to the game, or to go to the game, right? But equity is that everybody get good seats, so you can be at the game, but you sitting behind somebody before, wait, you can't even see the game, right? So that ain't equity, right? So the thing is that I'm excited that some of the things that the ADA is doing now, because they're bringing health equity as it relates to diabetes to the forefront. We have a Bill of Rights, health equity Bill of Rights for patients living with diabetes. And so those kind of things that are going to help level the playing field. There's another big thing that's happening that I'm excited and we can get through it. It just cleared the House, was the insulin affordability bill. I had a patient who has insurance, and even after her insurance, her copay for her insulin is over $140 a month. Okay, and so in this bill, the Build Back Better bill, if the Senate, if it is included in the version that the Senate approves, insulin will be $35 max a month supply. But there are other drugs that we need access to, that we need those same things. Like, for instance, type 2 diabetes typically associated with obesity. Patients often have high blood pressure and so forth. The drugs that we've been using for a long time really don't address those other issues. But we got new drugs like glucagon-like peptide agonists, such as, you heard them on, I don't like using brand names, things like this, but you've seen the commercials, and Trulicity, Ozempic, and so forth, those kind of drugs. Revolutionary because they not only, that group of drugs, the category, not only helps lower blood sugar, but without hypoglycemia. Okay, hypoglycemia will kill you faster than hyperglycemia. That's low blood sugar. Okay, they also help facilitate weight loss. The older drugs, promoted weight gain, and I just mentioned to you what's the most obesity, right? So you want patients to lose weight, but you give them medication to make them gain weight.
Mm.
So we need to have access. Those drugs just as important as insulin. My patients need to be able to get those kind of drugs for $30 or $35. Those who do not qualify for the services like at neighborhood medical center, but even at the federally qualified community health centers, those drugs are too expensive for our patients to use. And that's what we need to change. Yeah.
Oh, absolutely. Absolutely. You mentioned amputations, and I wanted to ask you about this, but how rampant are diabetes related amputations these days compared to years past?
Well, right now, most recent numbers I looked at, about 140,000 amputations occur, diabetes related amputations occur each year. And African Americans are 4 times as likely to have one. Okay. And a lot of this is associated with poor diabetes control. Okay. Diabetes is associated with chronic complications. One of them is microvascular complications, and that's diseases of the small blood vessels and things. So peripheral artery disease, things like that, where you have decreased flow into the extremities, whatever. Having access to exams that can assess patients' blood flow to their lower limbs and so forth, that can resolve a lot of that. But how often are those kind of studies, ordered? And that look at the disparity. Is there disparity in terms of the rates of those kind of exams being ordered for Black patients compared to other communities of of people? And so smoking is another big factor that's associated with that. And we know that a large percentage of the African American community, is that tobacco use is heavy. It's the one that tobacco, man, is worse. They're talking about pot. I mean, it's a vicious, vicious drug. And I call it nicotine a drug because it's heavily addictive. And, people are literally pulling around their oxygen tank, barely can breathe, and they still trying to smoke a cigarette. Who would want to do that unless somebody who is heavily addicted, right? So the smoking background, you smoking, using nicotine and so forth, that enhances the chances of you developing peripheral vascular disease that could lead to those amputations. Not having, good glucose control, because the high glucose levels make it, good medium for bacterial growth. So you got a combination of poor circulation in the leg. You cutting your nails. You got a hangnail. You pull it, it bleeds. You don't have enough oxygen coming down there through blood circulating for that tissue to heal. And whatever blood coming there, you got a lot of sugar in it. So a sore won't heal. That sore ends up taking a whole toll, and eventually depending on how bad the vascular disease is, you end up losing a whole, leg. So, yeah, so that's how a lot of it happens.
Wow. This is serious stuff. I mean, and what you just mentioned, I'm coming to you here from the south side of Chicago, all the environmental causes. There are food deserts here still. The community where I stay in, 6 or 7 years ago, there wasn't a grocery store within maybe 5 to 10 miles here. And you had to drive, usually downtown or further south, to get your groceries. So it's a really dire situation. What I wanted to ask you is, when it comes to African Americans and diabetes, what does the next 10 to 20 years look like? Do you find that future to be hopeful? Is it dire? What do you predict for these next 10 or 20 years?
We know that the rates are going to go up. But the question is, how will we respond behaviorally to that? I mean, right now there's about 34 million people with diabetes, right? 89,000 people, 89 million people with pre-diabetes. That's the group we really got to look at, okay?
Yeah.
Because type 2 diabetes can be prevented. It's documented. It can be prevented through lifestyle interventions, not with drugs. So what we have to do is we have to begin to teach our young folks how to eat right, how to eat healthy. Start them eating. Living as a as an obese, man, it ain't fun. Okay, and so one of the things, my grandkids, man, we encourage them to eat fresh vegetables, fruit and vegetables early on. So they can go to a restaurant and they'll order a grilled chicken salad instead of getting a cheeseburger, or whatever. But you have to explain. You have to expose them to that, you know. And so what we have to do is we have to find a way where we can promote the lifestyle behavior changes that are so desperately needed to change the projection of that curve. Okay, and so the diabetes prevention program proved that you if you establish 150 minutes of moderate exercise per week sustained, becomes a part of your everyday lifestyle, right? And you lose 5 to 7% of your weight, you can reduce your rate of develop your chances of developing diabetes by 58%.
Hmm.
That's profound. So how do we get there, right? So definitely we need to address those social determinants we mentioned earlier, making sure that the built environment is conducive to people doing those getting out to exercise. I mean sidewalks, parks and things of that nature. Making sure that we have access to healthy foods and making sure that people have access to primary care and mental care, health care as well. I think all of those things are will directly influence where we are. Now, I think that we're on the cusp of something happening, but we have got to put the momentum behind the federal government to keep moving in that direction, and that means that we have to advocate, we got to vote, we have to speak. We all have a role in doing this because you may not have the disease, but somebody in your family has the disease. And so it impacts all of us. It raises the cost of healthcare. Okay, you have people going to the emergency room, for primary care. Well, that raises the rate when you get ready. When you got to go for a real, for emergency, it
Yeah.
costs more money. And so those are kind of things that we have to work on in order to bend the curve on diabetes and hopefully see the numbers begin to decrease.
We're coming toward the end, but there are a couple of questions that popped up. One is, for the sake of our audience, because we primarily serve Black men and the people that love them, how have you seen it impact Black men and how we deal with it? Like, what have you observed in particular with us versus Black women, Black children, people of
Well,
other races?
yeah. Well, one of the things we know that it's difficult to get Black men to go to the doctor. Okay. The first thing, man, is to find out whether or not you have pre-diabetes or you have diabetes. You can't find that out unless you go to the doctor. And so I've found that a lot of Black men they don't want to go to the doctor. Okay. Now, oftentimes when they do, they develop diabetes and now they have erectile dysfunction. And I bring them to the doctor, right? But that means that you already have some neuropathy going on if diabetes is impacting your, if you have erectile dysfunction related to that. Diabetes also is associated with low T, testosterone. Did you know that?
Mm-mm.
So you get in your 40s and your 50s and so forth, your testosterone level is going to begin to go down anyway. Low T is we getting a lot. It's becoming more and more popular, but there's association between low T and diabetes as well. So you respect that African American men are disproportionately impacted by diabetes. You're probably disproportionately impacted by that as well.
Mm-hmm.
Um, I the Not all men are like that, because I have some African American men that I provide care to who are doing great. I mean, they're engaged. They're doing what they're supposed to do. Their A1Cs are down below 6. They get it. But in general, we think we are invincible. And we got time to do everything except what we really need to do. And we got to take better care, of ourselves. And so, in terms of complication, things of that nature, I don't have any direct data, offhand, to share with you on that. But just in general, we know that there's disparity in terms of, whether or not they go to the doctor. Uh, just look at what happens when you take your loved one to the doctor today. It take the women to get us to go to the doctor, man. A lot of times that's what it is. Or we don't go until something hurts. And that's a wrong, we don't need to wait until it begins to hurt or you're seeing symptoms, to go, now you're playing catch up. Because when diabetes is diagnosed, and remember type 2 diabetes is a very subtle disease. And so in terms of the symptoms, gradually, you get more thirsty, you don't realize you're drinking more water. People around you may begin to see that, but you don't see it, right? You go into the bathroom at night, a little more, whatever. But once it's diagnosed, or I won't say diagnosed, once it has been identified, you may already have in-organ involvement, meaning that the disease may already be affecting your nerves or your eyes or your kidneys, whatever. Okay, and so that's why it's so important that we go in and get that annual, checkup. And there are facilities out there. If you don't have insurance, very qualified community health centers are located throughout the country, and their primary purpose, the reason they were put there, is provide care to uninsured or uninsured people. So all you do is go online to HRSA, and I think that is what's the acronym? Just Google it. Federal Qualified Community Health Centers in your community. They'll pop up, and those centers can get access to medications at reduced rates. Okay, I mean, it's a tremendous service that they provide. So don't let not having insurance be a barrier for you going, because there are places there that you can get good care.
Absolutely. And as we're winding down here, what advice would you have for someone who may suspect that they're pre-diabetic, or maybe they are in their third or fourth generation of living and haven't been to the doctor often? What advice would you have for those people?
Well, first of all, one of the things you can do, a real simple thing, is you can download the diabetes risk test. You go to diabetes.org, that's ADA, you can get the diabetes risk test, and you answer these questions, they come up with a score. It'll tell you if there's a good chance you have pre-diabetes. The other thing is that, you got to go to the doctor. Okay, once the fear of the unknown, we have to get beyond that. Go ahead, find out what the situation is, and then take charge, become engaged, and make the kind of lifestyle changes that you need to make in order to ensure that you have a good quality, healthy life down the road.
Mm. And speaking of those changes, what do you recommend that somebody who just got the diagnosis or may have had it for a little while and are scared about not knowing how to really manage it? What specific things that they can engage in to help?
Okay. Um, Learn as much about the disease as you can. You got to empower yourself with knowledge, with real accurate information. There's a lot of bad information, wrong information out there. Okay. Develop a support network that can help get you through this. Number one is that, diabetes, like I said, it's a tremendous burden. You can't do it by yourself. There are other people. Your provider is part of your network. You got relatives and so forth part of your network. Do that. Work hard on developing lifestyle that facilitates weight loss and maintenance of that weight loss. And that includes eating healthy and getting out and being active. Believe it or not, physical activity is a tremendous benefit in terms of glucose control. And so getting out there, and we're not talking about going and running a marathon, we're saying 150 minutes, 5 days a week. That's 30 minutes, 5 days a week. It could be 15 minutes in the morning, 15 minutes in the afternoon. If you're sitting down and you're doing like you at the computer like I am all the day, I keep this right here, which is a resistance band. You can do that sitting down. There's different things that you can do, but you have to work to create your plan. Set your goals, make sure they're real, they're doable, and try and assess whether or not you can achieve those goals. It's a continuous cycle, and the important thing is that don't give up, man. Because there's help out there. But that is really it in terms of, and if you having a session with a diabetes educator could go a long ways, because they will help you understand the foods that impact your blood sugar, the foods that don't, foods that help that increase your risk of heart disease and those that don't, and so forth. And you need that kind of information in order to make everyday decisions at home when you're preparing your meals.
Absolutely. Absolutely. And Dr. Kirksey, thank you so much for your time. This is, I think, really valuable information that needs to get out in the community, because this is a serious problem. John Brown, our founder, he always says this, but, especially with Black men, we're the worst and the first, right? We're the worst at going to the doctor, and we're often first in how these diseases like diabetes and prostate cancer and even COPD and how they impact us.
Yes.
You mentioned the smoking issue that we have in our community. With that said, is there anything else you'd like to add, or maybe some resources you could throw out that could be helpful to people?
Sure. First of all, if you have any questions or related to diabetes, or if you even have problems in terms of finding affordable insulin and so forth, go to diabetes.org. That's American Diabetes Association's website, and they have many, many resources that can help you maneuver through this maze in the diabetes space. Got access to healthy recipes. They have information on exercise, on monitoring, and so forth. But that's an excellent resource that you can go to. Also, the National Diabetes Education Program. If you're a community-based organization and you're trying to educate, the community, whatever, you can go to that website. They have a lot of non-copyrighted print information that you can actually download, print out, and give out, and use it as you try to, outreach to patients living with the disease.
Wow. Well, thank you so much for your time, Dr. Kirksey. This was really helpful. We really appreciate it here at blackmenshealth.com. And at some point, we would like to have you back. Would that be okay?
I would love to do it. Love to do it.